All right, so actually the first video was stopped because I didn't have enough space in my computer to save, so that just kind of stopped. So this adrenal disorder lecture will be divided into two lectures because I did not want to go back and record it again. All right, so I think we stopped at to give the lowest dose that will manage the disease being treated for the shortest possible duration. So remember, we need to really give the lowest amount, shortest duration possible to minimize adverse drug reaction from corticosteroids. And corticosteroids can cause stomach issue, GI discomfort, and also remember from prednisone acronym that it can cause peptic ulcer disease. So taking with food is really the key counseling point that you need to tell patients. And patients who have been on long-term steroid therapy will need to be gradually withdrawn towards physiologic doses over a month. And this is because of HPA axis suppression that we're going to talk about in the next page. So, and then caution should be used to prevent disease exacerbation during the steroid taper. So these are the 2 points why we need to taper really carefully and slowly taper corticosteroids. So remember, there are two reasons. One, when patient has been on long-term steroid therapy, that is more than physiologic doses that can cause HPA axis suppression. Second, sometimes patient hasn't been on long-term steroid therapy, but when there is any risk for disease exacerbation, depending on what we're treating, that we need to taper the steroid even if it was not for long-term therapy. So there are two different cases that we're going to talk about. All right, so there are two reasons for tapering steroids. And last, avoid concurrent administration of the drugs that can inhibit or induce glucocorticoid metabolism, and these are mainly CYP450 inducers and inhibitors that comes up in any other drug therapy management as well. All right, so let's go over glucocorticoid withdrawal, and this is something that I think we need a good understanding because we will see this case a lot in community practice setting or any practice setting in general. So when do we withdraw glucocorticoids? Of course, when maximum desired therapeutic benefit is obtained, that we treated what we were trying to treat with corticosteroids, especially for any inflammation. If it's all controlled, then we're going to stop the therapy. When it's not working, then we need to stop. There's no reason to give corticosteroids and exposing patient to adverse events from corticosteroids. And sometimes when adverse events is way too serious and uncontrollable, that we such as osteoporosis and hypertension, that really the risk is way higher than the benefit we can gain from the corticosteroids, we're gonna stop it. And when the case is between these two, that it was long term and then can cause disease exacerbation, that we will need to slowly taper. However, there are some cases that we don't have to taper, or we can taper. We have to really immediately stop the glucocorticoids, even when patient will develop either withdrawal symptoms or disease exacerbation. Those are when patient has steroid-induced acute psychosis. I already mentioned earlier that when patient has acute psychosis, we will stop corticosteroids right away. Or when patient has herpes virus-induced corneal ulceration, this can lead to blindness. So we are going to stop corticosteroids right away. Other than this case, if the case is between these two, long-term use or disease exacerbation is a concern, we are going to do slow tapering. All right, so what is HPA axis suppression? So hypothalamic pituitary adrenal axis is this. So basically, kind of similar to the axis for thyroid gland. The stimulation comes from hypothalamus and interior pituitary that goes down to adrenal cortex. So hypothalamus will produce CRH, which is a corticotropin releasing hormone that stimulate enterial pituitary to produce ACTH, which is corticotropic hormone that triggers adrenal cortex to produce now cortisol. So when there is enough cortisol, that's gonna produce that it's gonna send negative feedback to pituitary and hypothalamus. Then that will stop the production. That will stop the cycle. So when we only have physiologic amount of cortisol made, this will keep going and really keep the homeostasis and make how much we need when we need cortisol. However, when there is too much amount of cortisol, especially given exogenously, that's going to lead to negative feedback. And when the consistent and constant negative feedback is there, then it can lead to HPA axis suppression. So exact dose and duration for HPA axis suppression is really unknown, but we know that even any supraphysiologic dose, anything more than our natural cortisol level, even one dose of it can cause HPA axis suppression. However, when it's been given for longer term, that cause adrenal atrophy, kind of similar to muscle atrophy. So remember, when we don't use muscle for a while, when anybody is bedridden due to any accident, that you're not moving, you're walking for a while, your muscle will suffer muscle atrophy. So you have to really go through rehab. We have to be able to walk again, kind of like that. When HPA axis has been suppressed for long term, that it really needs time to recover from it. To be able to start making cortisol again on its own. So even though we don't know exact dose and duration for it, we expect that some suppression with prednisone dose greater than 20 milligram daily for 3 weeks or longer. So anytime, so remember, for immune suppression was 20 milligrams daily for 2 weeks. For HPA suppression, anything more than 3 weeks is what we consider, we can know that there is going to be some damage with HPA axis suppression that we need to consider. We need to really taper the dose. And then when patient who has clinical Cushing syndrome, that so we're going to talk about Cushing syndrome later on, but it's basically patient having adrenal too much adrenal issue. So for that case, when patient has that syndrome, we need to stop corticosteroids gradually. And abrupt cessation or too rapid withdrawal of glucocorticoids in patient with HPA suppression may cause symptoms of adrenal insufficiency, because your adrenal cortex will not function to make cortisol, so you're gonna go into this adrenal insufficiency stage. So remember, this is not gonna cause insufficiency in mineralocorticoids or aldosterone, because this is how HPA axis is how it regulates the production of corticosteroids. But remember, aldosterone or mineralocorticoids are regulated by rest system, so it's totally different system that is regulating either one. So HPA axis suppression will not interfere with the production of aldosterone. All right, so remember that corticosteroid tapering should be considered to prevent either disease flare or adrenal insufficiency. So this is, it doesn't matter with the duration of therapy, but if there is any concern with disease flare, we will taper. And then adrenal insufficiency is concerned when patients taking high dose prednisone dose greater than 20 milligram for longer than 3 weeks. So remember something like Medrodose PEG. So that one is short course, like just 6 days, but that dose PEG is made really to taper slowly over the course of 6 days. So that's a great case that even though the duration is short, that it's not likely to cause HPA axis suppression, we still taper because whatever we are treating, usually poison ivy is here. Poison ivy is most common reason for giving macrodose pack. We worry about disease flare. That's why we still taper, even though there is no adrenal insufficiency that's likely to happen with just short day, 6 days course. So again, disease flare is of a concern, like autoimmune disease such as rheumatoid arthritis. Any frail, very ill patient, we are gonna consider tapering. When patient has history of flare or anything withdrawal symptom in the past, and patient who has Cushingoid symptoms, having too much adrenal cortisol, we will taper. And these are the case we actually don't have to taper because either disease flare or adrenal insufficiency is not a concern. So any course that lasts less than 3 weeks and there is no reason for here, so there is no concern for disease flare, we don't have to taper. We can just stop right away. So this will come up a lot. So treating asthma or COPD flare for 1 to 2 weeks, we don't have to taper because again, this is a short course and we don't have to worry too much about asthma and COPD flare. So we it's not likely to happen. So we don't have to taper for this one. And any allergic reaction that we are treating, we don't have to taper. And then again, when we are stopping corticosteroids for really severe adverse events such as what we already mentioned, psychosis or this herpes virus ulceration, corneal ulceration, we don't have to taper. So again, remember there are 2 reasons and there are different cases. So general recommendations for corticosteroids tapering: taper slowly. There is no one set rule. Really all depends on how patient respond and depending on their underlying illness, other comorbidities. And then you may need to increase the dose and slow down the taper if patient has any flu-like symptoms or disease flare. So flu-like symptoms will be withdrawal symptoms, and disease flare is if your concern is disease flare. And consider switching to a shorter acting agent, multiple daily dose to single morning dose. So or converting to alternate day dosing. So slowly taper down, and then consider increased dose of supplemental dose in times of stress. So whenever there's any stress, we may have to increase the dose really to accommodate those stressor. All right, and now going a little bit into the disease itself. So adrenal insufficiency is when we don't have enough of either mineralocorticoid or glucocorticoid steroids. So the types are either primary, which is known as Addison's disease. So Addison's disease is autoimmune destruction of the adrenal cortex. So basically, adrenal cortex is not making any of this anything. So it's not making both glucocorticoids and mineralocorticoids. So we need to replace both. However, for secondary reason, usually it can be from the disorder within the HPA axis. So it can be either pituitary gland or hypothalamus that has something to do with it that does not give signal to adrenal cortex, or the majority of the case is from abrupt discontinuation of exogenous glucocorticoid therapy. So because of the HPA axis suppression, it's causing adrenal insufficiency. So for the secondary reason, it's only glucocorticoids that is being affected. So you need to replace only the glucocorticoids. You don't have to worry about mineralocorticoids because again, that is regulated by rest system. So we don't have to worry about replacing mineralocorticoids. So symptoms are weakness, fatigue, anorexia, nausea, salt craving. That's from mineralocorticoid deficiency, dizziness, hypotension, again from mineralocorticoids, dehydration, weight loss, tan appearance, hyperpigmentation. This is one of the hallmark sign of Addison's disease. So there's some saying that when patient looks great, tanned, but feel awful, that is a sign of Addison's disease. So again, the salt craving, hypotension, tan appearance, they're going to be shown only in primary case, not really in secondary. So treatment, we are replacing, so this is a treatment for primary Addison's disease. So for Addison's, remember that we need to replace both glucocorticoids and mineralocorticoids. So we need to give either hydrocortisone or cortisone that they have both glucocorticoid and mineralocorticoid activities. And we're giving higher dose in the morning because that's when our cortisol level naturally peaks around 8 a.m. Remember that, right? And then give another smaller dose in the afternoon, and then it'll slow down and then kind of trying to really mimic our physiologic rhythm and level of cortisol. And fludrocortisone or brand name Florinef can be given only when we need to replace more of mineralocorticoids. It can be sometimes used for hypotension, but mainly for patient with Addison's disease when they need more of mineralocorticoid. Usually, just giving hydrocortisone or cortisone should be enough because they exert about same amount of glucocorticoid and mineralocorticoid activity. And this has to be given by monitoring blood pressure. That's how we really titrate the dose. The acute setting is either called adrenal crisis or Addisonian crisis. So this is endocrine emergency precipitated by severe stress. And remember, when we naturally, when we have a lot of stress, illness, infection, stuff like trauma, our body will naturally produce more cortisol to really compensate that. But patients with adrenal insufficiency, especially Addison's disease, they are not going to be able to do that, so they can go into this acute crisis. So for this case, patient will have to be hospitalized, and then or at emergency room they're gonna be given high dose IV hydrocortisone to quickly replace that need, and then also fluid replacement is being done. So to monitor Addison's patients, symptom resolution, blood pressure, for mineralocorticoid replacement, weight, electrolytes, and of course monitor use of CYP3A4 inhibitors and inducers. Counseling points: to take dose prior to 9 a.m. to mimic physiologic level of cortisol, carry ID warning bracelet. So these are all for Addison's disease patients. Use more dose when ill, may need to use injectable form for any of those stress situation, and do not discontinue abruptly because they're gonna cause HPA axis suppression. All right, lastly, Cushing syndrome is basically having too much cortisol, so excess of cortisol in the plasma, or it's called hypercortisolism. So excess chronic glucocorticoid therapy, so iatrogenic cause, so basically giving too much of an exogenous corticosteroids therapy. So this is really the most cases. And true endogenous Cushing's disease is caused by overproduction of ACTH, the hormone from anterior pituitary gland. So when there's a tumor or any that's leading to overproduction of ACTH, that's leading to too much production of cortisol. So this is a true case of Cushing's. All right, so symptoms very similar to prednisone mnemonic that we just went over on the first page, of course, because it is having just too much corticosteroids. So central obesity and facial rounding, so we call it moon face, and red cheeks. Those are it's a hallmark symptom, and buffalo hump and fat pads on your and then striae, so some red marks and red and purple stretch marks on the central areas. Hypertension from too much mineralocorticoids, myopathy and muscle weakness, hirsutism because there is that kind of interruption with sex hormones, glucose intolerance again, from messing up with carbohydrate metabolism, and increase in gluconeogenesis, acne, amenorrhea, all having something to do with sex hormones, depression, and osteopenia. So these are all pretty similar to, again, prednisone acronyms, and this is the presentation of patients who may have Cushing's. Really, the treatment is surgical. Really try to fix pituitary adenoma if that's what's causing it, and then or irradiation of pituitary gland, or if it's drug induced, really tapering, slow tapering, and discontinuation of glucocorticoid as soon as possible is really the key point for any exogenous source. There are some other drugs that you may see in the textbook. Really, surgery and discontinuation of glucocorticoids is a mainstay of therapy. So I'm not going to really go over that because you are not likely to need to know that. But if you're interested, you can read the textbook as well. But they're not going to be on the test. So that's all I have for adrenal gland disorder. Again, if you have any question, feel free to email me or ask me questions during the case conference on Thursday. All right, thank you guys and have a great evening.